It's a great pleasure for me to introduce Dr. Avi Kuperschlag for today's webinar. Avi, Dr. Kuperschlag, thanks very much. Dr. Kuperschlag is an accomplished oral surgeon. Just a few notes about Dr. Kuperschlag. He's an accomplished oral surgeon and faculty at the Oral and Maxillofacial Department of Kaunas Hospital in Kaunas, Lithuania. He's a renowned lecturer on tissue regeneration and implantology. I met Dr. Kuperschlag a couple of years ago, and I was really impressed with his clinical work, his research work, and specifically, obviously, utilizing autologous tissue, and especially Dentin graft, to achieve highly aesthetic, long-term, predictable results. So Dr. Kuperschlag will definitely focus on techniques that I believe you will be able to implement in your practice as soon as we all get back to work, right? With that, just before I transfer it over to Dr. Kuperschlag, my name is Amit Binderman. I'm with Cometa Bio. As far as Q&A, questions and answers, if you have questions at any time during the lecture, please feel free to use the chat box and type in your questions, and we will either respond to your questions right away or we will keep them for the end of the lecture, and then I promise you we'll answer as many questions as we possibly can, okay? So with that, I'd like to transfer the lecture to Dr. Kuperschlag, and thanks again for joining. We have over 200 people on the call. It's great. Give me 1 second. I'll transfer it over. Let's see here, 1 second. Okay.
Okay, hello everybody, just 1 second. Okay, can you guys hear me?
Yes.
Okay, perfect.
Yes.
Excellent, excellent. Okay, so first of all, just let me open this window. Perfect. Okay, so thank you for the very fine introduction, Amit. I'm very humble. It is my great pleasure to be here tonight. I want to welcome all of our participants. Say good evening to the guys from Europe and the Middle East. Good day, good afternoon to the guys from the other side, the US and Canada. My name is Dr. Avi Kuperschlag. I'm an oral surgeon. I focus my practice on implant dentistry, and the purpose of my presentation is basically to show you as much of clinical data that I can in order for you guys to be able to implement it the following day after all of this quarantine, corona stuff ends and passes it. So let's jump right in. What's on today's agenda? Well, we'll be discussing grafting materials, the pros and cons. Then, of course, we will be discussing the reason why should I choose Dentin as a grafting material. We'll be talking about PRF, or focusing a little bit more on L-PRF, on leukocyte-enriched, platelet-rich fibrin. Then we will talk about, obviously, the indication using Dentin grafting, which contains of ridge socket preservation, immediate implant placement, impact of third molars. This is where I get the most eyebrows raised when I state that as an indication for grafting, but stay tuned and you will see why. And obviously, I will give you clinical tips and tricks that I established from my experience, from my clinical experience, and the whole purpose of it is pretty much to make your life easier when you're doing surgical work. So before we jump into Dentin, let's talk about when do we use biomaterials, or more when do I use them, because the list of indications is very vast. So I'm just gonna state out the most pronounced ones, the most obvious ones, and the most common ones that they use. So the first one is obviously socket or ridge preservation. We extract a tooth, we fill it with biomaterial, in this case Dentin, we close it somehow, in this case with a PRF plug, and we basically pretty much prepare the area for future implantation. Then obviously we do GBR, both lateral or vertical augmentation. In this case, we're using collagen membrane fixed with tissue tags. We place, it's pretty much a sausage technique. Here we have a mix of 50-50 of autologous and xenograft and xeno type material. We close it with the membrane. On top of that, we place the PRF membrane, the L-PRF membrane, and this is very important, and we will get to it later. Why I like to place, and this is a question that I always get, why do I like to place the PRF over the membrane rather than over the graft, and on top of that, the collagen? So I have, I think, a very logical explanation for that. And we suture and we move on. Obviously, for immediate implant placement, filling in the jump gap. 1 second, I'll just close in this window. Yeah, so filling in the jump gap during immediate implant placement, I think roughly around 70% of my implantations include immediate implant placement. And we often see a case like this, which is a canine that has just been extracted. We see here the osteotomy with the Densa birth. Thank you, Professor Mazot, for the technique. We place the implant and pretty much the distance in between the buccal wall and the implant body is what we refer to as jump gap. It has to be grafted, especially in anterior maxilla, where we have very thin buccal plate. About posterities we can discuss, but in my opinion, when doing immediate implant placement, we can't cross a jump gap. In a case like this, it must be issued. So in this case, I close it again with the L-PRF, and the patient now is just ready to go home and wait for the future. We can also call this not exactly a jump gap, but more of, let's say, socket preservation, because here we have an upper first molar that was extracted, an implant was placed. I performed a closed crustal approach sinus lift using Densa bird, and now basically we had a 3 rooted teeth that was extracted, and we are dealing with 3 different sockets. So the sockets are grafted. In this case, we fabricate an individual healing abutment using flow composite, close it, and the patient is ready for the future. And this allows us not only to hold the biomaterial, but also to maintain a nice emergence profile. What about extractions of the impacted third molars, wisdom teeth extractions? Why are we doing this? And we will address this question a little bit into more depth later on with the lecture, but on one leg, and we will again emphasize that the extraction process itself, the surgery, is quite aggressive. We need quite a lot of bone removal. This has nothing to do with our technique. It's just the situation that we're dealing with, and we're basically creating a future, let's call it future problem, future defect. So this is a way to address this defect, and we will talk about it more thoroughly soon. So speaking about grafting materials, their pros and cons, we have a few types of them. We'll just really shortly mention them. We have autogenous bone, which is pretty much the golden standard, right? Everybody who learns GBR always learns that the autogenous bone is the golden standard. Why? Because it's the only type of grafting material that's both osteoinductive as well as osteoconductive. Okay, we have no immune suppression. The patient hosts accept it, and we have osteoinduction, meaning that we have new real bone formation. It also has a fast turnover. However, and that's a big plus, it requires a secondary surgical site for harvesting, and another, let's say, con or minus that we have using autogenous bone is that it's a little bit more, not a little bit, it's more technique sensitive, especially if we're talking about blocks. And I love doing blocks. I do a lot of Kuri technique, which is a cortical bone plate. However, it's very technique sensitive, and we must remember. Also, not always the patient wants to have a secondary surgical site, right? I mean, I think that it's a normal request, especially if we're doing somewhere on the aesthetic zone on the anterior maxilla. Imagine harvesting a bone block from the ascending ramus, right? Completely other region in the oral cavity, and patients really don't like it. Us surgeons, we love it, but patients not so much. Then we have, of course, allogenic bone. It's harvested from human cadaver through a donor bank. It has a fast to medium turnover. It contains BMPs, bone for genetic proteins. However, it's not osteoinductive, it's osteoconductive. And in my hands, and also some authors mentioned that it's a little bit less predictable in the long-term run, stability-wise. Some authors even claim to have about 30–35% of resorption over a 5-year period of time. From a personal point of view, when I started doing GBR, I started with allogenic. And when I reopened, amazing. You see bleeding bone, everything looks nice. But 3–4 years after, you start seeing recession. And this is something that in my hands, it's quite unpredictable. Then we have the xenogenic material, which is bovine or porcine. It has higher contact of minerals. This is also why you see it a little bit different in the X-rays. Sorry, it has slow or no turnover. And the biggest issue with that is that we don't really have real bone formation. We have more of a bony-like substance. Now, remember, this material does not resorb. So everybody who works with xenografts, and I personally work quite a lot with xenografts, I still do. When we reopen, we find a lot of unintegrated particles. So yes, they are type of a filler. It maintains its volume, but it's not real bone. It really isn't. So looking through the table, I didn't mention one type, which is synthetic. I choose not to talk about it because we are a little bit lacking in long-term information. A lot of companies really promise us the world and beyond, but I think that we should wait at least to have 5-year post-op data and be very, very responsible by using it. I'm not saying that I never use it, I do sometimes, sorry, but we must be of course, responsive. So obviously the golden standard is the autogenous. However, as I said, we have the problem of harvesting and having a secondary surgical site, and also the technique sensitivity. So basically, it's a great material. I mean, we can not call it a material, right? It's our own. It's real bone and blood and cells and so on and so on. However, it requires much more aggressive surgery. So what if I can tell you that you can use autogenous graft or autogenous materials? It has slow resorption, which is quite similar to xenograft, right? The autogenous bone has a very fast resorption. It has a very fast turnover, and it does not require a surgical site. Well, if we would be having this conversation, let's say 10 years ago, then you'd say, ah, Avi, you're a charlatan. But I'm not. And this is where Cometa Bio and Cometa Bio's Dentin grinder comes into use. So in 1967, it was first published that Dentin is containing the bone for genetic proteins by Utriest, this team in UCLA. And in 2003, it was first described as a grafting material for a sinus floor elevation by a team of South Korea. Now, Dentin has inorganic and inorganic and organic components that are quite similar to those of human bone. Okay, in Dentin, the inorganic content is about 70–75%. The organic is about 20%. If we compare to the alveolus, to the alveolar bone, then we have quite similar numbers. But, and this is a very, very important data, that at least 90% of the organic content of Dentin is type 1 collagen. This plays a very important role in bone formation and mineralization. And as we mentioned before, it also contains BMPs, which are very important for osteoinduction. So how did I came across dentin grinding? Well, this is a photo of me with much more hair. I was a student here. I think I was either in 4th or 5th year. And I came across this article. This is a literature review from a South Korean team about the properties of dentin using for grafting materials. And I mean, I was stunned. I read this. I was still a student. This also motivated me to do my final thesis work as a student about dentin, about the grafting possibilities of dentin. And I read this article and I was blown away. And I thought to myself, I mean, why aren't we funding this? Why doesn't everybody uses that, right? This is the number one question. Why isn't dentin being used routinely in oral surgery? And then I figure out why, because in South, sorry, not in North Korea, but in South Korea, they have what's called a Korean tooth bank. And back in the day, and that was a few years ago, when you extracted a tooth, you give it away by a courier or however, they demineralize it and send it back to you. But this process takes time. I'm not even talking about the financial model of it. And I mean, if I said that we're using for ridge preservation, for socket preservation, for immediate implants, 70%, 80% maybe of our indication has blown away. So yeah, that's why it wasn't known. And what I like to use for metaphor is these cute donkeys. And the fact of the matter is that we're a herd. We're followed by biomaterial companies, colleagues, opinion leaders. And if everyone says that they need to do one thing, they usually do it. However, a lot of times, if you just think straight, you can figure it out much more comfortably and easily. So the donkey was Kometa-bio, right? So yeah, so that's when I came across Kometa-bio. They were a very small company back in the day. I contacted them. I already graduated and I wanted to get as much information as possible. And I remember just maybe a couple of months, of maybe 3-4 months maximum, after I started working, I already started implementing this protocol. And this is a very, very simple and easy protocol to use and very predictable. What they found out is this type of protocol that consists of, first, you have to clean away the tooth from any soft tissue remnants, from filling materials, from caries, and so on and so on. Please make sure that you're using a surgical tungsten carbide or just carbide burr. Do not use a diamond coated burr because it doesn't cut. It generates heat. We don't want the heat there. Then we clean them off, dry them with a gauze, make sure that they're nice and dry. We can take the air gun and spray it with air. We grind and sorted. It takes 13 seconds. Well, I think a little bit more because I run it through several cycles. So let's say instead of 13, it takes 30 seconds. Not a big deal. Then we clean and rinse it. And this takes also about 6 minutes and we're good to go. We have this amazing grafting material. Now, what are pretty much the clinical problems in using extracted teeth as grafting materials? So first of all, we need to get the correct size of granules, right? The optimal size, in my opinion, is not larger than 1,000, let's say 1,300, 1,400 micron. I like to use, in any type of biomaterial, small to medium-sized granules. I never use the big ones, especially when I'm in the sinus. I just find it more risky to handle. So, and obviously smaller than 250 microns will go through phagocytosis. So the immune response will treat it as a threat and will just be completely resorbed. Then what about the caries and the bacterial infiltration? I mean, a tooth is not a sterile thing, right? Tooth is in the oral cavity would know how bacteria full the oral cavity is. And we will expect some caries and bacterial infiltration to our tooth. How do we address that? And this is where Cometa Bio shines. This is their big breakthrough, in my opinion. And can all extracted teeth be used as grafting materials? And I'm here pointing you towards endo-treated tooth, and we will get to that in a second. So it is a very complicated process. In order to get the exact granule size, all you need to do is press a button. I'm joking, it's extremely simple. Basically, the Dentin grinder does it for yourself, does it for ourselves, I mean. You just press a button and it grinds it and it shortens it. It has a filtering mechanism that maintains the granules on that specific size. So it pretty much does it for ourselves. It's idiot-proof. What about caries and bacterial infiltration? And again, if you take a look at the grinder itself, it's pretty much a high-quality, high-tech coffee grinder. It comes from the same idea. But this is where their breakthrough is, and they have developed this infection solution that is used in order to disinfect it. I'm specifically saying disinfected and not sterilize it because we don't have a sterile graft, but we don't need the graft to be sterile because it's autogenous. So we just apply it on the grinded particles on the graft. We wait for 5 minutes. After 5 minutes, we take a gauze, a sterile gauze. We soak up the excess liquid. Then we place a buffing solution. The buffing solution pretty much neutralizes it. We place it. We soak it again with another sterile gauze, throw these gauzes away. And again, we fill up this Dentin dish with the solution and we're good to go. That's it. So it takes 5 minutes to disinfect and maybe 20 seconds to buff it and neutralize it. Very, very simple, very easy to use. And believe me, you can teach your assistant to use it, to do it for you. It's very, very simple. What about endodontically treated teeth? Well, I'm going to start from the beginning. No. And I see a lot of people advocating on Facebook that they can remove the endomaterial and the gutta perca. Well, obviously, you don't want these materials, these synthetic materials that are most probably contaminated inside our graft, right? The other thing is, even if you think visually that you are able to remove everything, in some places they use arsenic-based depulpation paste. Some of the sealers are toxic and so on. And believe me, us surgeons that worked in the OR, we know that when you play around, you mess around with these things, and when we have a complication, it's not a complication, it's a disaster. It will lead to necrosis. We will need to do resection, and I just want to avoid it categorically. I think Cometa Bio also emphasizes not to use endodontically treated teeth. So I am very much insisting on endodontically treated teeth to be contraindicated for grafting, unfortunately. Now, let's talk a little bit about L-PRF, okay? The main objective of it is to achieve new angiogenesis, right? New formation of blood vessels. So the mechanism, as we all learned in second year of studies during physiology, is that we have injury, then bleeding, then we have a blood coagulation. From the blood, we have a fibrin cloth that releases growth factors and from the platelets and the leukocytes. They have some cell communication, and we have eventually wound healing. All of that is very nice. what does it give us practically speaking? And I'm not going to teach you the microbiology or the biology of L-PRF because people can do it much better than me, and we don't have time for that. So basically what it does, it releases growth factors for up to 7 days. It's used also as a matrix recipient for growth factors. Now, these two are these two properties, the next ones that I'm going to mention, are very significant from a clinical point of view. It does not resorb it epithelialized. And this is why I always put it on top of as the last layer before I suture, on top of the collagen membrane if I'm using one. Because if I will have wound adhescence, right, wound opening, we all know that if we have wound opening, we start over, right? We remove, we start over. In that case, if it's still at the membrane level, at the L-PRF level, then I know that I can leave it like this. It will eventually epithelialize and we will have growth and closure of new gingiva. I only instruct my patients for good oral hygiene. It also has antibacterial properties, which means that we have no plaque accumulation. This is also extremely important. You will not find any plaque on there if you leave it for spontaneous healing. And it, of course, reduces the use of antibiotics by quite a bit. So what's the protocol? We take a 21 gauge needle. Okay, it's a butterfly needle. We do a phlebotomy. We collect 8 to 9 milliliters in the red cap tubes. We centrifugate them at 2,700 RPMs using the centrifuge for at least 12 minutes. Okay.
Avi.
Yes.
Avi, give me 1 minute. I want to pause this for 1 minute because we have more people joining us and we need to reclaim the host for a second because of the technical difficulty we had. So
no problem. I'm stopping for a second.
Okay, so hold on, Yasmin. If you can take the host and bring more people in the waiting room to join us. And also, if I may ask everyone, if you can mute your video. Okay, you know, so you can still hear and see, but just mute your video.
It's okay.
Right.
I hear nobody. So.
Avi, you can continue.
Yeah, I hear you, Yasmin.
All right, we have 55 new people in the chat. Go ahead.
Excellent. Okay, so welcome to all the new participants joining in. I'm just about to discuss the L-PRF protocol, how to get the L-PRF, and I'm just gonna repeat it from the beginning. So we're using a 21 gauge butterfly needle. We collect blood in the red cap tubes. We have about 8 to 9 milliliters of blood. We centrifugate them at 2,700 RPM with our centrifuge for 12 minutes. After 12 minutes, of course, if the patient is taking anticoagulative drugs, then we can prolong it for 18 minutes, up to 18 minutes. This you verify during the anamnesis when you take the patient's history. After the centrifugation is over, we take off the clots from the tubes. We place them we separate them from the red blood cells and we place them in the box. This is how it looks.
Yeah.
I hear somebody, Yasmin, can you just mute everybody for me?
Yeah.
Thank you. So we place the clots in. Okay, now we're good? Okay. So we have the clots, we close the cover of it, press it down, and then we have the L-PRF membrane. Now, from my personal subjective point of view, why did I start using them? First of all, it's evidence-based. If you go into PubMed, you type down L-PRF, you get over 1,800 results. So it is evidence-based, but I mean, there are a lot of things that are evidence-based. Do they work in our hands? Are they predictable? And just a little bit of personal experience, when I just started practicing oral surgery, I was working in 2 different clinics. In one clinic, we had the centrifuge, and my assistant was a certified nurse. She used to draw blood for my patient, for every patient. Simple extraction. I take 2 tubes of blood, and we make membranes, and we fill up the socket, and all the way to the more serious or let's say complex surgeries. And in the other clinic, the same, only without. I didn't have any PRF, any nothing. And I saw with my eyes, and I heard the patient post-op complaints that are much less the healing of soft tissue. And this is the main idea. And I will show you a couple of examples how soft tissue reacts to L-PRF. It's amazing. It's simply astonishing. So I thought to myself, okay, I have to start using it on a regular basis. And I went down and I bought the centrifuge, and I'm using it for over 6 years now, I think, maybe 5. And I have great results, really amazing results. So when I'm preparing for a course, for a class, I always go through the literature. And here we have a very nice systemic review from 2017. Look at the names: Zucchelli, Pico, Salame, even Joseph Shukun, Ziv, you are missing there. How can it be? The conclusion is very, very simple, that we have a very strong evidential support for periodontal and soft tissue repair. And this is what I'm talking about. I mean, gingiva, soft tissue heals amazingly, and it reacts amazing with PRF. And also, we have little data. That was in 2017. Now we have a little bit more data, but still, regarding GBR, guided bone regeneration, we have a little bit of work to do. We still, in some cases, cannot rely strictly on L-PRF for membrane. So how do I use it? Practically speaking, right? What have you been talking to us about? Everybody, every agent that sells the tubes and the centrifuge is saying the same thing. Practically speaking, how do I use them? And it's very simple. I use it as a poncho, meaning that I take a membrane, I puncture a hole in it, I place my healing abutment through it. When doing immediate implant placement, this is a lower first molar. We placed an implant, we grafted the area, we suture it, I cleaned off some of the particles there after I sutured it. And look what happens 5 days after, when the patient comes for suture removal. Look at these defects in soft tissue. Only 5 days. These are my pictures. I can show it to whoever wants it. Amazing. And this is something predictable, and predictability is the key for success in any field of medicine, not only dentistry. Everybody can reproduce it. It doesn't only work in my hands, and that's what makes it so nice. And I mean, it's easy to use. There's no fancy surgical techniques about it. You puncture a hole with a scalpel, and you just place 2 sutures. 1 suture, single interrupted suture, nothing fancy. Now, L-PRF and autogenous dentin, in my opinion, can you just please unmute everybody for me? So in my opinion, they are best friends, best buddies, let's call them like this. Combining these 2, we can make what's called an L-PRF dentin block. Some people refer to it as sticky bone or sticky dentin. We call it a dentin block. And how do we do it? 1 second. Okay. Hang on. You guys see me, I hope. Okay, it just popped up a few slides in advance. But let's just go through each section separately. So when we are drawing blood, we are using 1 tube without any coagulation additives. Okay, this will be always the last tube that we draw. Make sure of it. we centrifugate all the tubes together for 3 minutes under 27,000 RPM, so same RPM, only now we're centrifugating them for 3 minutes. After 3 minutes, we remove that tube that has no coagulation agent. And we continue on with the centrifugation for the rest of the tubes for 9 more minutes. So in total, we said for membranes, 12 minutes and 2,700 RPM, okay? We draw the fibrinogen serum from that tube to a sterile syringe. We put it on the side. We can use it up to around 25, 30 minutes. But once it's made, you can leave it for hours. After the centrifugation, we make the membranes the same way, the same fashion that I just showed you. Then we take 2 membranes, chop them finely with scissors, mix them with the dentin, and make sure that the dentin is as dry as possible. Just use a gauze, dry it up, mix it nice and thoroughly, and then we spray it with the syringe. We mix it slowly. Don't overmix it. Don't be very hectic about it. Just take your time and believe in it, and it should happen within 10, 20, 30 minutes, seconds. I'm sorry, seconds. What a big difference. 20 seconds, and you will get a dentin, wonderful dentin block that looks like this. And a little bit more focused, like this. This is very, very malleable, very easy to use. You can press it down, you can manipulate it, you can force it into 4 or 3 wall bony defects. Very, very simple to use. Now, Ziv Mazor, Professor Ziv Mazor, who's a great mentor of mine, teaches a lot of things. And during one of his courses, I came across with the term green dentistry. And out of all of the things that he emphasizes, I don't think that green dentistry gets the respect that it deserves. So Ziv, green dentistry, a little bit, push it more. And I just love it. I find this term to be fantastic to explain what I'm doing, because green dentistry, I'm taking medical waste, right, an extracted tooth, okay, that was supposed to end up in the trash can. I take blood from the patient, I mix it up, and we have this amazing biomaterial, and we are green here. That's just amazing. I'll just show you a quick example. I'll show you the full case at the end. But here we extracted an impacted wisdom tooth of a lady. I will explain that case a little bit more thoroughly, and went on with placing an immediate implant here. We grafted it with a dentin. Here we have some PRF in the socket, and cover all up with PRF ponchos and membrane. And that's how I sutured it. And that's how I send the patient home. And you might sit at home, obviously everyone is home now, and think, why are you showing this to us? This is nonsense. Look at this terrible surgery. Believe in green dentistry. Look at the results 5 days after. Not a week, not a month, not 10 days, 5 days after a suture removal. Look how beautiful the tissue is. Look how healthy it is. Look at the volume. Look at the maintenance of tissue. Before, what a mess, and after. And this is something that you will get every time. And I don't claim to be some kind of extra fantastic surgeon. I do my best, but this is something that is very, very predictable. And I'm sure that everyone can get the same result. Think about it. This combination of dentin and L-PRF. This is growth factors over growth factors. This is so rich in all of these cells that help tissue repair and regeneration, that we are expecting it to heal quite well. And this is her already after we delivered the prosthetics. We use mostly full contour. That means monolithic zirconium screw retained prosthetics. Okay, I'm sorry for the low quality. Corona does not allow me to go to my office and do screenshots. So all I have to show you is that when I did the CT, I was so amazed that I took some photos with my phone just to show everybody. This was done using xenograft. This was also an immediate implant case. Look at the difference in the opacity. Now this is 2.5 months post-op. Where is the dentin? Where is the host bone? I cannot see the difference. Look at the cross section. Where is the host bone? I don't know. And this to me shows regeneration. This to me really shows a good result and good outcome. Okay. So being autogenous and talking about green dentistry, let's talk about the indications, right? Again, the same indication. We have socket preservation, extracted a tooth, grounded it up, disinfected. Here, it's mixed with the exudate from the PRF that is left at the bottom of the PRF box. We fill it up, and just 3 sutures. We close it with a PRF plug. That's how it looks. The patient, I'll show you a little bit in more detail this case. Also, the patient later on had a provisional Maryland adhesive bridge at the time of before we placed an implant for him. What about immediate implant placement? Well, this is a lower first molar that I just extracted. And using Densabers, again, Viv, thank you for the info, for the knowledge. Look how nicely I was able to expand the septum. This is why osteodensification also works with the concept of green dentistry, because we're not destroying anything here. We're only manipulating the bone. That's amazing. Again, if you would show me this photo 7 years ago, I would say it's Photoshop, but it's not, and everybody can get the same result. I was fortunate enough to have a little piece of that tooth that I extracted. It was a vital tooth. It wasn't endodontically treated. We placed the implant, grafted the site, and again, poncho, and happy patient, happy doctor. And believe me, when I say to the patient, dear sir or dear madam, I'm going to use bone taken from a cow and close it with a membrane taken from a pig, or I will use your own tissue or your own blood and your own tooth for grafting material, you'll be surprised to know what's the most common answer. Now, talking about indications, I want to emphasize this topic. I just published a paper about it, and we use the grafting material to graft post-extraction socket of an impacted wisdom tooth. Why would you even consider grafting wisdom tooth? For what? This article should be free in Cometa Bio's webpage if you want to check it out. So basically it goes the following. The horizontally impacted wisdom teeth, 1 second, let's wait for it to pop up. The surgery as is, and it's regardless to your technique, and I'm going to talk about technique in a minute, and I'll give you those great clinical tips. But as is, it's a very aggressive surgery. I mean, if I have a fully impacted wisdom tooth, I have to do the osteotomy. I have to expose the tooth. It has nothing to do with my technique. This is the situation that I'm dealing with, okay? So I am creating a bony defect. And due to the large osteotomy, like I said, we're creating a bony defect, and we're expecting to have a pocket depth of 4 to 7 millimeters. Okay, we have literature published about this, and also it correlates with my results. So basically, the surgery itself is quite aggressive, and we are unfortunately making a defect. We're causing a defect, and we're making it. Now, a lot of people who practice oral surgery will probably relate to what I'm saying now. Most of the patients that that we're getting, that we're extracting the impact of wisdom teeth are referred patients. They come from other clinics. We do the extraction. Sometimes they come back a week after to remove the sutures. Sometimes their own doctor removes it for us. That's it, we forget about them. But imagine, most of these patients are young patients. They're in their 20s, they're in their teens, most of them, right? Not all of them. We're causing a defect that that patient has to live with for another 80 years, maybe 100, hopefully, right? Can we do something about it? And the answer is yes. The answer is absolutely yes, we can. 1 second, the computer is okay. So let's look at this case, this number 48. Sorry for my American friends. I'm using the European numbering system. So we have a lower right third molar. And look here at the distal aspect of the wisdom tooth. We have a pocket here. There's nothing to discuss, right? Now imagine that I also need to remove the buccal area, the buccal aspect. So that means that the option of a 5-6 wall, sorry, the 5-6 bony wall defect and spontaneous healing is not so much in a case like this. And that has nothing to do with my technique. It's just a situation, the given situation. So in this case, we extract the tooth, look at the amount of bone that is lost here. And again, instead of throwing it out, instead of having medical waste, we have this amazing grafting material. We grind it up, disinfect it, we place it in the socket, suture it up, and the patient will go happy and live their life. So in our study, the mean pocket depth assessment was done 3 and 12 months post-operative after surgery. We had in total 24 cases. And look at the numbers. At 12 months, the study group, the group that was grafted, the control group was not grafted, had a pocket depth of 1.15 millimeters. That's an amazing number because the physiological depth is up to 2 millimeters. I think in some cases we can also accept 3, but here it's 1.15. And look at the probing depth of the control group, 4.45. This correlates and coexists with the data that is already in the literature. And pocket depth means periodontal defect, periodontal pocket. And again, imagine these patients are young. They have to live with that for many, many years. So basically we have a new paradigm here. And again, I'm emphasizing is that we're taking medical waste and turning it into a great grafting material, and it improves our patients' long-term health and reduces the risk for future complications. So very nice. Now, being autogenous, right? And this is where the practical part of the lecture begins. So thinking of all these indications, right? We talked about socket preservation, immediate implants, wisdom teeth extraction, but the key for success is performing atraumatic surgery. And I'm specifically saying atraumatic, not minimal invasive. We are invasive. We're raising a flap, we're invasive. Sometimes the invasiveness can sometimes be dictated by the existing factors. We don't have control over it. So it all begins with a true atraumatic extraction. And I'm going to explain to you and share with you my protocol of achieving that, and hopefully you guys can implement it in your daily practice. So the aim of the atraumatic tooth extraction is to preserve as much hard and soft tissue as clinically possible, and using the right instruments together with the correct technique. You can't have one without the other. So you can have awesome technique, but you don't have the instruments, you will have to be more aggressive or more traumatic. You have all the most fanciest and most expensive instruments. You don't have the right technique, you will be more aggressive. So speaking about the instruments, sorry, we have three major instruments: the periotome, luxator, and high-speed carbide or tungsten carbide surgical burrs. What's missing? I'm not. I cannot hear you, so don't scream forceps in your living room. But I didn't mention forceps. Forceps is not a part of our instrument case. Forceps are only used at the last, and I cannot emphasize it enough, at the last step when the tooth is completely loose. We do not use forceps for atraumatic protocols. So what's a periotome? A periotome is an instrument with a long, sharp shank. It is used to cut away the PDL, the periodontal fiber. Basically, if you remove the periodontal fiber, you eliminate the holding mechanism of the tooth. This will allow the tooth to be extracted along its long axis, and it prevents me from all of this buccolingual, buccopalatal yanking that needs to be done. How do we use it? Very simple. Parallel to the long axis of the tooth, from the buccal, from the mesial, from the proximal. You can go even from the palatal, never go from the buccal. Start off slowly and apply apical pressure. Don't apply too much pressure at the beginning. You know, sharp instruments and then pressure and a lot of force, they don't coincide. Okay, and just you will feel the instrument going deeper and deeper in the sulcus. That means that you're cutting away the PDL fibers. Then, of course, we have the luxator, which is very similar to the elevator, only it has a much thinner shank. Now, in my practice, I don't use elevators at all. I don't want them. I don't need them. Not for me. Everything, every indication, every extraction is done with the luxator. If my personal favorites, I always use three major types. It's 3 millimeter thickness, 3.5, and 4.5. The one that I use the most is the middle one, the 3.5 millimeter shank thickness. It just works for most indications in my hand. And as I said, it has a thin shank, and this allows me to have a fulcrum point in between the root and the alveolus. Okay, not necessarily, I don't have to have a fulcrum on the adjacent teeth, and it's of course used to fully luxate the tooth being extracted. And we use it either along the long axis of the tooth, or more of a traditional matter. Now look at this case. This is lower second molar. The adjacent first molar is missing. Here I already dissected separated the roots. And I know that due to the existence of the wisdom tooth of this third molar, I have a fulcrum point, right? I can just use it in a very straightforward fashion, 90 degrees, rotate it, and it will, sorry, can you just mute everybody, Yasmin and Amit? So you can just rotate it and it will pop most likely from the medial part. What about this area? I don't have any fulcrum. Now imagine engaging it with an elevator. It will be a nightmare. You'll have to remove some bone. But here, all I have to do is just jiggle it in. I will find the spot, and you will find the spot, and it goes out without a problem. The third major instrument is the surgical burr. Tungsten carbide or just carbide burrs on the right-hand side of your screen. This is called a Zakaria. The other ones, every manufacturer has a different numbering system. I prefer this configuration. I prefer to have only the apical part cutting, meaning that if I have some contact with the gingiva, with the tongue, with the adjacent tooth, with the cheek, whatever, I will not rip it open. I will not cut it away. I will just maybe a little bit braze it, but we sometimes can live with it. Of course, we need to pay close attention to provide it, but this is just another safety measure. And make sure that you are using sharp new burrs, right? Because like a kitchen knife, A sharp burr is a safe burr. If it's dull, then you're forcing it. You're applying pressure, and then you have more chances of slipping and hitting some structures that are not meant to be hit. And also make sure that they are long. I usually use 27 or 29 millimeter long burrs. Okay, so they're used for multi-rooted teeth separation, single-rooted teeth dissection, and minor osteotomies. Very, very minor. And remember this, the bone belongs to the patient. The tooth belongs to me. I extracted it, it's mine now. The bone belongs to the patient, and I want to be as minimally aggressive as possible. So this is how I use them. This is a lower first molar. Note that I'm not going all the way to the lingual. I'm not separating it, or I'm not doing the separation. Please mute, because I hear some people talking and it's hard to focus. So I always separate about 80 to 90% of the tooth. This area, the lingual area, is very rich in blood vessels. I don't want to have the slightest option of hitting it, because then we will have bleeding and it's potentially life-threatening. So I always try to go about 90%, and then I finish the separation. You know where this came from. The distal root, and in this case, we go on to perform an immediate implant. We have a very nice septum here. In other cases, we use them for dissection of single-rooted teeth, okay? And I will give you the protocol exactly and show you how we use them. Now, this is the time. This is the final part of the lecture. This is the time where you do the print screens, where you screenshot, where you photograph it. I'm going to show you the Atraumatic protocol, and I made three parts of it according to the tooth segment. So the anterior teeth, and it's regardless to whether it's maxillary or mandibular anterior teeth. First, I use the periotome to cut away the PDL, just like I showed you before. Then I use the luxator along the long axis of the tooth to luxate it. Now, if the tooth is ankylosed, or still, I don't know, there's some anatomical destructions in the root or whatever, and it's not moving, we decoronate it and use a burr. We decoronate, meaning we remove the crown. We use a burr to dissect it in a mesio. Always I do a mesiodistal dissection, not a buccolingual, buccopalatal dissection. And when the root is completely mobile, or when the tooth is completely mobile, only then I can remove it with forces, but I never apply this palatal or buccopalatal, buccolingual rotation, okay? And again, remember, the tooth belongs to the surgeon. The bone belongs to the patient. Make sure that you follow this guideline. So here's an example. This is a lateral incisor. And in this case, the patient, as you can see, if we go back, is not taking good care of his teeth. And all I had to do is place deep my periotome, and just popped out. That's it. And easy extraction. Now, this patient was referred to me from periodontist. He has a vertical root fracture. We have a pro and exudate, and they decided that this tooth is hopeless. Though this tooth is not endodontically treated, it's not necessarily vital, but it's not endo treated. So we have also lovely grafting material. Now, I tried to place the periotome somewhere here, nothing. I tried to place the luxator on the proximal contact. All I got is slight movements of the adjacent teeth. So what do you do now? Nothing is moving. You take forceps and you go to town, right? Wrong. Remember, if it's not moving, decoronate it and dissect it. And now I'm treating this tooth as a multi-rooted tooth. I first extract the palatal side, then the buccal side. Sometimes, if, let's say, the buccal or the palatal or whatever part is not mobile, we can furthermore dissect it. Okay, so this is, imagine, this is the palatal area, and I furthermore dissect it, and I remove the tooth in three parts, 1, 2, and the palatal. Now, believe me, I'm an oral surgeon and I don't use a turbine that often. If I can do it, everyone can. Make sure that you're going all the way to the apex. If you're not sure, then do an X-ray like endo, leave the instrument inside and do an X-ray. This will tell you if you reach the apex or no. Anyway, you should feel it because the consistency, the hardness of the tooth is much harder than bone. Bone is much softer. So just make sure that you go all the way. This is very, very important. Now look at this patient, okay? And I'm talking about this tooth. So the plan here is to extract, this is a canine, very long root. Of course, canines have long roots, especially in the upper jaw. And the plan is to extract and place an implant and place an implant, an immediate implant here. Well, this is a very difficult case because this is my mother-in-law and she lives abroad and we have to stick to the plan. And even worse, her prosthetic doctor was assisting me, and her prosthetic doctor, her prosthodontist is my wife. So you can imagine that I have my wife assisting me, my mother-in-law in the chair. Everything has to be right. Look at the situation. I don't think that anyone can say that this is an easy extraction. It's not an easy extraction. We don't have any adjacent teeth. Here what it is, it's a temporary filling. This tooth is contraindicated to use for grafting because she had some devitalizing paste put into the root. So it's a big no-no. And difficult situation to begin with. But we placed the periotome. We can, I was able to force it in a little bit on the distal. On the mesial, nothing, no way to breach the sulcus. Now we're dealing with a crownless, ankylosed, long-rooted canine, hard case. But look how easy we can solve it with the right technique. We do a dissection. This is where the long burrs come in handy. Very easily, I remove the palatal segment. And then with a luxator, I remove from the same area where I reached in with my periotome. I remove the buccal part, and we go on placing the implant. This is the buccal, obviously, this is the palatal, on the singular area. So a difficult case, a challenging case that took me 3 or 4 minutes to extract, not because I'm amazing. I'm a very average, I think, surgeon, but because I'm using the right technique. And believe me, you guys can do it as well. Just have the right instruments for that. What about premolars? So pay attention to the first upper premolar. Usually has 2 separate roots. We all know this shape. Sometimes, a lot of times actually, you find the septa after you remove them. So of course, after analyzing the X-ray, we can determine it, and we just use the same surgical burr and separate them, and just extract it from the point of view that it's a single-rooted tooth. Of course, before you start dissecting the root, use the periotome to cut away the PDL fibers. Okay, and be wary of the lower premolars, especially the second lower premolars. They're quite often very close to the mental foramen, mental loop, mental nerve. So pay close attention not to go through the apex and not to go through the buccal area. And another thing that I want to emphasize, an extraction has to be, we have to be able to manage an extraction flapless. Do not raise a flap. When we are raising a flap, we are cutting away the periosteum from the buccal plate. We'll have bone loss. We will lose keratinized tissue. We will lose the emergence profile. We anyway will lose some of it, but without it, if we raise a flap, then we just increase the risk of bone resorption and so on and so on. So make sure that you keep your extractions flapless. So how do we approach them? Again, we have a theoretically difficult case, right? Look at this decay. It's a very badly decayed first molar. Like I said, two separate roots. We have fulcrum here. However, you can imagine just placing an instrument, you will just remove small bits. We all know this feeling where you start luxating and you just remove these decayed particles. And I cannot use the distal area for fulcrum because look at this. We have some old filling. I will apply a little bit of pressure and everything cracks. So this is a hard extraction. And look how easy we can solve it. Just dissect it, remove the mesial root, remove the buccal root, then remove the palatal root, and go on with our lives. What about molars? So I am doing this protocol to each molar, unless it's third degree or second degree mobility, as I can just pluck it out with my fingers. Every molar, regardless of whether I'm placing an implant, the patient is going back to his restorative dentist or whatever, if I won't even see the patient, every molar, upper or lower, I extract using this protocol. And the first stage is to decornate the root, the tooth. Then we separate the roots. We do a hemisection or a T-section, trisection in the upper jaw. We remove each root separately using a luxator. And we all know this feeling. Sometimes one of the roots or neither of them is moving. We just further more dissect the roots. And I will show you that in a second. Okay, so this case you already seen before, about 80%, 90% of the separation. I don't go all the way lingually. I don't want to risk it. I finish the fracture with the luxator. Always tell the patient, don't get frightened. You'll hear a crack. It should be. This sound is normal. We remove the mesial part. We remove the distal part. And in this case, like I said, we went on for immediate implant placement. Look at this patient. I really wanted to show you this. She came to me with a failed bridge. Okay, we obviously have nothing to do with these teeth. And analyzing the X-ray, we can see that this one, the wisdom tooth, has been tilted due to the 3-unit bridge that was previously on it. Look at the periodontal space, quite wide, so we know that we shouldn't have a problem. We just apply the luxator in this area when we will remove the tooth, and it was like this. Now look at the first molar. Where's the PDL? We have an ankylosed tooth, and we quite often see ankylosed endodontically treated teeth that were used for holding bridges as an abutment teeth. She comes to me, she had these implants with a colleague quite a while back. They look excellent, but she tells me, doctor, listen, it's now or never. I want to have immediate implant placement here because I suffered a lot. This experience was very, very traumatic for me. I was swelling, I was in pain for a couple of weeks. I will not go back to you again. Like if you cannot place the implants immediately, then just leave the area eventually. No pressure, right? We have to make it, and we have to rely on our technique. So here I extracted I extracted already the wisdom tooth, and I did the separation. I know that the mesial part will be a little bit easier because I have fulcrum, and it was. I extracted it quite easily. If we go back, I raise the flap only to expose the area of future implantation. The flap ends somewhere around here. I don't raise the flap all the way to the extracted tooth. Okay, as you can see, this is the septum. Okay, this is the septum. What I did is I just took the burr, I went in all the way to the apex, dissected the mesial part, removed the lingual aspect, removed the buccal, and look at this beautiful septum. Traditionally, what are we taught? That in a case like this, maybe raise the flap, maybe don't. Take a burr and just go around it, right? In a circumferential manner, and remove it until you are able to luxate it and to find some fulcrum. Nope, forget about it. No osteotomies. The tooth belongs to you, to us, to me, to the surgeon, to the whoever is performing the extraction. The bone belongs to the patient. Try to avoid that as much as possible, especially if we're going for immediate implant placement. So I was able to nicely extract this tooth. We basically took a difficult extraction and solved it with the right technique and instrument. And it took about 7 minutes to do. And look at this nice septum. We go on placing 2 implants, and happy patient, happy doctor. What about upper teeth? Again, every molar, I do the same. First, make sure that you decoronate it, especially if you have some ILM, some temporary filling material, remove it. Do a 3-section, T-section, however you want to call it. Make sure that you don't go too deep. You want to preserve the septum. Again, if you're not sure, do an X-ray, although you feel it. I always start with the buccal roots. Always the palatal root will be the last one because it's the largest. Here I extracted the mesial, then I went on to the distal and the palatal. I end up with this, and using densa burrs osteodensification, I performed closed sinus lift, placed an implant, and we did preserve these sockets by grafting them and fabricating using flow composite and temporary peak abutment. In this case, it's a temporary healing abutment from peak. Make sure that this healing abutment, I call it individual healing abutment. Some authors call it SSA, socket seal abutment. Make sure, call it wherever you want, make sure that you highly, highly polish it to allow biology to work without a problem. This is what we give to the patient, and she comes back 4 months later. Look at this beauty, beautiful emergence profile. We were able to preserve all the tissue. We fabricated ceramic fused to zirconium UCLA type bridge with a very highly polished collar according to the zero bone loss concept. This is the emergence profile, beautiful. And this is the patient, happy doctor. This is the final X-ray. So again, talking about green dentistry. This is one of the cases that I showed you from at the beginning. This lady in her 50s came like this. I placed an immediate implant here. She had a vertical root fracture in the lower first molar. I placed an implant. She didn't want to do anything else, even though I advised her to get rid of these teeth. Said, okay, I will do it in a month and 2, everything will be okay. And she disappeared, like we often get. She comes back almost a year later, and doctor, I want you to put the prosthetic on it. At that time, at the time that this photo was taken, we already had pearl and texodate. We have pus running from this impacted wisdom tooth. This tooth cannot be held in place. It's all decayed. So listen, lady, I'm very, very sorry. It's my way or the highway. Either we extract these. If you want, I will place another implant here. But these teeth have to go. If you do not want, then you have an implant passport. Everything is okay. You can find a different doctor. I cannot do something that's against my philosophy. said, you know what, I trust you, do whatever you need. So we exposed the wisdom teeth. Now look at the, again, because of Corona, I cannot reach the office to show you the pre-op X-ray, yeah? But look at the angulation. Look at, this is the second molar. So can you imagine the angulation is like this? Extracted it, beautiful grinding, beautiful grafting material. We mixed it up with some L-PRF exudate, grafted, one-stage surgery, always, let's say 95% of my immediate implant placement cases are one-stage. Again, we cover it with the L-PRF membranes, and voila. Amazing, amazing, amazing results. Okay, this is the emergence profile, and this is the final prosthetics. And again, look at the X-rays. You cannot differentiate the host from the graft. Amazing. Again, green dentistry. This lady, and we only have a few more cases, and we will be done for today. I'll just have a sip of water, if you don't mind. So this lady came to the office, also referred for extraction of wisdom teeth. She had some pericornitis. She's already in her late 40s. You don't want to keep these teeth in the mouth. You don't want to have the possibility of some kind of infection in this age next to the throat. Just take them out. And doctor, what do you think we should do with these teeth? I said, what do you mean? Extract them and place an implant. Here, if you look at the first molar, second premolar, it looks quite close to the mental foramen, but we had a CBCT, and we verified that we have a safe distance. So we decided to go for a stage approach, and I'll just show you one side. Stage approach meaning that we do one side, then a few weeks after we do the other side, just for the patient's comfort. So this is the way that she came in. Okay, you can see the wisdom teeth. You can see the teeth that has to be extracted. There is no discussion here. We extracted the wisdom. We extracted the teeth to be extracted. This little bit also was removed. Look at this wisdom tooth. Beautiful grafting material. It's not medical waste. It's green dentistry. So we placed 2 implants with PRF ponchos, closed it up, and again, green dentistry. No biomaterials, no expensive biomaterials, very comfortable, eventful healing for our patients. Happy patients, happy surgeon. Another case of green dentistry. So this patient came for extraction of, he's a male in his 50s, smoker, came for extraction of anterior lower 5 anterior teeth from this canine until the lateral incisor. Already we can see here a defect. And this is the clinical view, obviously not the best oral hygiene. We extracted these teeth. Of course, oral hygiene education is essential. It's really essential to success, and we really post up our patients and make sure that they keep good oral hygiene, and they do. They usually do, because they're already motivated, and I'll show you why. So look at these beautiful teeth. Medical waste? Nope, it's green dentistry. We will grind them, disinfect them, and use them. Here, I said be flapless, but because we have a defect, and I also wanted to flatten out a little bit these bony interproximal peaks, so we raised a flap with one distal releasing incision. I very rarely do 2 releasing incisions. I do an envelope flap like you see. I think that the vascularization of a flap design like this is superior. We go on placing 3 implants. This defect was grafted with, of course, our autogenous dentin, covered with some PRF. We splinted the transfers, took open tray impression, and usually this is my protocol for immediate loading. The patient comes 5 days after we remove the sutures. I usually don't do it in the same day because, or the following day we have still swelling, edema. I prefer to wait 5 days, 5 to 7 days. He comes, we place multi-unit abutments, and we provide him with a fixed bridge. Now, this is a much better situation than what he started. Usually when they see this, it motivates them, and this is the motivation for them to keep good oral hygiene along with our instruction. Another case of green dentistry, terminal dentition, nothing to do here. The patient cannot afford a fixed solution, so we decided to go for biomaxillary removable dentures over locators. So we have some stabilization agent from the implants. Now, one looks at this and says, okay, extract. I'm looking at this and saying, grafting material, perfect, green dentistry. So in this case, I wasn't able to draw blood from him. It was just impossible to find veins. Whatever I did, I tried from here, I tried, impossible. So I just aborted it, and I know the properties of dentin. Dentin, unlike other materials, does not encapsulate. So you don't have to use a membrane for barrier, okay, as a barrier from soft tissue infiltration, from fibroblast infiltration. You just can leave it without a membrane and it will heal without a problem. Knowing that, I approached the surgery. We extracted the teeth. Again, go flapless, but because we are going for a removable denture, we need to prepare the platform. So we raise the flap and flatten out the alveolus, did an alveolectomy. Even though it's for removable denture, we still place the implant in the correct prosthetic position in the palatal area. This is the second implant, this is the third implant. Beautiful grinding, beautiful green dentistry material. Grind it up, disinfect it. Look at the amount. This is a huge amount, really. And we just fill up and close it. Now, the plan is that within about 3 weeks, 2 weeks after, the restorative doctor will start preparing the removable prosthetic. And within about two months after, he will already start wearing the prosthetics. And 4 months after surgery, we uncover it and directly connect it with the locator system. What are you doing, Avi? Is everything okay with you? You're going to place removable denture over a grafted area. What's wrong with you? Why are you doing this? Well, first of all, I know that it's not going to be immediately. It's going to be about 2 months after. And I know that dentin integrates very, very fast. So I was confident enough to do it and look at the time of exposure. Where are the implants? Where are they? Look at this. This is how a grafted area should look. Live, real, bleeding bone. Here I have to dig out this implant. I use the burr to remove it. And this is the case every time. And again, I'm not selling you some fancy membrane or some fancy bone material. Autogenous, green dentistry. And this is about 6 months or 7 months after he was already had the denture connected with the locators, and this X-ray is at the time of uncovery. Beautiful, 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 beautiful. Now, the last case that I'm going to share with you is how I approach third molar extractions. I know that for some of you, it's interested because I get a lot of questions about them. So first, what we need to do is analyze the X-ray. Okay, we have almost a completely vertically impacted molar tooth. It is seen inside the oral cavity, and the game plan is like this. First of all, we do a coronectomy. We remove the crown, analyzing the X-ray. Then we will find the fulcrum point somewhere here, And if we still have no movement, then we go on to hemisect the tooth and remove it, remove each root separately. So as long as we have a plan, we're good to go. So this is the situation. Okay, this is the flap design. Now note please, I'm doing the flap from the buccal area. I never go mid-crestally, and lingually there's not a discussion. You cannot do it because in some cases, some authors even state 18% prevalence. I think that this number, I don't know how they got it. It's much lower, but still, I don't want to risk the possibility of damaging the lingual nerve. Okay, leaving the patient paralyzed. I mean, not paralyzed, but leaving the tongue without sensation. It's terrible for the patient. So what I do, this is the flap outline. I try always to go without a releasing vertical incision, and I try not to go through the papilla, the mesial papilla of the second molar. So the flap is relatively small. However, I'm working with nice magnification. I can see everything, you will be able to see everything, and I don't see the need for it. So I try to preserve this papilla. So this is what we get, and this is the clinical situation. Now the next step to do is to perform a bone gutter. We're going from a little bit distally, from the buccal area with a burr, and we're just making a bony gutter. Another tip that I can share with you, dear colleagues, is that before I start guttering the bone, I place somewhere the luxator, and I just a little bit luxate the tooth, because I want, after I separate everything, after I finish all the separation, for the area already to be luxated and free. So I do the bone guttering, then like we established, I go for the coronectomy, and I place my luxator in this area, find the fulcrum, and I was lucky enough for it to pop out quite simply. Again, look at how much grafting material I have there. That's a lot. That's a lot of grafting material from one molar tooth. I graft the area, 3 sutures, 4 sutures. Again, no need for fancy membranes. No need for, you can do it with PRF. There's no problem with that. Only in our study, we didn't want to combine it with PRF. We wanted to show that you can strictly do it only with Dentin. Now imagine, from a perspective point of view, this will work with whatever biomaterial that you are using. However, if you want to use allograft, and in this case, I wouldn't want to use xenograft. I want to use something that turns over completely. I will need to use at least 1 cc, right? And I will need to cover it with a collagen membrane. These things cost money, and I end up charging the patient at least twice for the same procedure, at least twice, if not 3 times more, because I cannot pay for it from my pocket. And the patient will look at me. We're usually dealing, as I said, with young patients, and say, "What are you talking about? Like my colleague, my classmate, my cousin got his wisdom tooth extractor with all of this mumbo jumbo. Now you want to charge me 3 times more? What the hell?" And with Cometabio, the cost to ratio is very, very logical, and I would say 8, 9 times out of 10 patients agree for the extra when you explain to them how it's beneficial for the long run. So this is the last topic that I wanted to show you. Thank you very much for your attention. Please, everybody, stay home, stay safe, wash your hands. This is my Facebook, Avi Kuperschlag, Instagram. You can find me at dr.Avi Kuperschlag. This is my email. Please feel free to contact me if necessary, if you want to discuss something, and so on and so on. So thank you very much, and Amit, I give you the stage.
Okay. Okay, Dr. Kuperschlag, can you hear me? You can. Okay, very good. Wonderful. First, thank you very much. This was fascinating. It was great. Appreciate it. We did get a few questions throughout, and I'd like to go back to them and then maybe answer a few more that are coming in now. So first one is, can we when we clean up the tooth after the extraction using a burr, just like you showed, do we leave the cementum on top or not? And the answer is, I'll take it, Avi, unless Yasmin, you can unmute Avi as well. But definitely you can leave the cementum on the tooth. That will basically resorb fairly quick. Cementum resorbs really quick as a granule, as part of the particulate, so absolutely no issue there. And when you are cleaning the tooth before you placing it in the smart dentin grinder, you basically have to take off any soft tissue, any gingiva, PDL, and of course any restoration. So if there's amalgam, usually the amalgam is easier to take out when the tooth is still in the mouth, just as a tip. But any other restoration, any sort of filling or composites, you need to take that out. But as far as the cementum, you can definitely leave that there. It will typically take you about, I would say about 2 minutes, 1 to 2 minutes, depending on the shape of the tooth, to clean it up before you can place that in the grinder. Okay, if the tooth is fairly nice, fairly clean, it will take you a matter of a few seconds. Second question was about.
Amit, if I may,
Sure.
this is a very common question that I get about cementum and about enamel.
Mm-hmm.
Pretty much every other person asks me about it. The enamel always comes up, and I have my opinion about enamel is that I leave it because enamel at the bottom line is hydroxyapatite, which is very similar to xenograft. However, practically speaking, we do not use the enamel because the enamel as is, the crystals are very, very brittle, and the grinding process makes them so brittle that they're usually below the 250 micron level. So we have very little enamel if is. However, no problem of using it.
Yeah, exactly. As far as the cleansing, there was a question about, can we use the autoclave in order to sterilize the grafting material? I'll just give the brief answer, and then Avi, you can, Dr. Kuperschlag, you can elaborate. But our recommendation is no, do not use your autoclave. The protocol comes with a cleanser kit, which is a dentin cleanser. It's a high pH liquid that does an excellent job on completely disinfecting the particulate. In fact, when we check it afterwards, it's the same as sterilizing it because you've got nothing, no bacteria is left. The great thing about our cleanser is that it will maintain the BMPs, the growth factors, and the collagen that are embedded in the particulate. So it's actually very effective while maintaining the properties of the dentin. Okay, so, but the most important thing is really the wash. So after you go through the 5 minutes of the dentin cleanser, you then have to wash out the particulate using PBS, which is, again, is part of the kit. And then that will basically rinse away the cleanser and will bring the dentin graft back to pH 7.2, which is the biological pH you want to introduce the graft back into the site at.
Yeah, so I completely agree. Also, logically speaking, autoclave is a heat and pressure chamber, basically. Autoclave kills cells. We want to keep these BMPs, these growth factors in there. Now, one interesting thing that we discovered in our study is that at least at the beginning, when patients came back 7 days post-operatively for suture removal, they filled out a questionnaire. And a lot of them reported more swelling than the control group from using Dentin. And what I found out is that we didn't emphasize enough after we used the cleanser, and I emphasize cleanser, make sure that you soak away the excess cleanser with the gauze thoroughly. It will take you 3 more seconds, but just pay more attention to that. And only then apply the first coat, the first dose of PBS, soak it, and apply the second coat. This actually neutralizes it. And I think that our mistake was that we didn't dry enough the graft after we used the cleanser on it. So learn from my mistakes. Make sure that you dry it thoroughly and go through 2 cycles of PBS.
Another question came up earlier when you presented the Smart Dentin grinder is, can we use the particulate if we have leftover? Can we use it for later on? So of course, many times we would graft the site, but then we know we might need to have more graft for once we place the implant if we're doing a delayed implant placement. And the answer for that is definitely you can. It actually saves really, really nice, and you can save the graft, the excess graft that you're preparing for many, many years. And there's some studies that show that that show why this is so. The one thing to remember though, and we do have a protocol for how to do it, is that you really need to dry the graft completely. Whatever you have left over, you need to completely dry the graft and then store it in a safe place with the name of the patient. You can only use it for that same patient. You cannot use it for anybody else. You can't use it for a family member of that patient, only for that specific patient. That's another question we get asked a lot. And then remember that when the patient comes back, let's say 4 months later, 6 months later for the implant, and you want to use the graft then, you have to repeat the cleansing process. So at that point, just before the surgery, you want your assistant to use the dentin cleanser and then the wash. Make sure it's, again, absolutely clean, just in case, you know, something happened to it along the way, and then you can use it. Then you can use it again.
Completely agree.
Another question came up here is, can we use the graft if we don't have enough for any reason? If we were doing a big site, let's say we're doing a full ridge, can we mix it with other grafts? Can we mix it with synthetics? Can we mix it with xeno or allografts? And the answer to that is absolutely you can. So it doesn't have to, you don't have to just use that. If you want to mix it up with something else just because you need more or for any other reason, you can certainly mix it. Is that how, did you try that before, Dr. Kuperschlag?
Well, Amit, the answer is a huge yes. And let's think about what we're dealing with. We're dealing with autogenous graft. Don't treat it as dentin. Treat it as autogenous graft. One of the most well-published follow-up types of GBR, especially lately, the team of Boozer from Switzerland has published the book of 30 years of GBR. They're calling it the composite graft, right? That with first layer use autogenous bone chips, and on top of the xenograft. Instead of scraping for autogenous bone chips, use the dentin on top, place a xenograft, collagen membrane, you're good to go.
Okay, good. Another question came up is for large sites. So if we're not doing a socket, if we're doing a large defect, let's say a large perio defect that we're trying to, so you mentioned, Dr. Kuperschlag, that you're not using in quite a few indications, I see mostly sockets, you're not using a membrane. You don't find the need to use a membrane, but then in the large defects, you do. Can you talk more about that?
Of course. So this is a question that also I get asked a lot. And in order to answer it properly, we need to think about what is the purpose of using a membrane, okay? So we have pretty much two major, we have a little bit more than that, but two major indications. The first indication is graft stabilization, because we all know this is the first lesson that we learn when we're studying GBR, that the graft has to be stable. In that case, we are using a membrane. We are fixating the membrane, whether it's periosseal sutures, whether it's pin tags, membrane tags, stabilization tags, like I like to do. And in that case, it doesn't matter which material we're using. because we have a mechanical property of the membrane that holds all of this graft material in place. For example, if you look at the sausage technique by Ishtavan Urban. But the other indication is to have a barrier from, and I a little bit talked about it, from infiltration of soft tissue cells, mainly fibroblasts. Now, dentin, as is, do not get encapsulated. So these fibroblasts have no clinical significance for me. And in that case, for example, if I'm just doing a simple socket, I can even place a hemostatic fleece on top of it, an X suture just to hold everything in place so we don't have it running away, and it will heal. My best scenario is to use PRF, but as a membrane, as is, classically speaking, to use a membrane as a barrier, whether it's resolvable or unresolvable, it is not necessarily necessary when using dentin.
Okay. There was a question a few minutes ago, and the question is, what is the difference between dentin graft and demineralized dentin graft for remodeling new bone? So let me take this one, because this is a big question, and we get
it's very big
all the time. There's a lot of discussions around this, and I'll just explain what the question is. The question is basically about the difference between mineralized dentin graft and demineralized dentin graft. And on the market, we, Cometa Bio, we offer two protocols, but there's other companies that offer fully demineralized dentin graft protocol. So the big difference is the scaffold. So when we demineralize dentin, we're basically eliminating most of the mineral, and we are exposing the collagen. So the great thing about this is that you get collagen exposure earlier on, and so you get more new bone regenerated early on. But the downside is that you're losing a lot of mineral, and the mineral we know is very important for the scaffold. You want the scaffold, and you want the slow resorption, and Dr. Kuperschlag highlighted it earlier on. The slow resorption is so important because that is what's going to get all your woven immature bone and will support it to for the bone to turn to lamellar bone, mature bone, which is really what you want, because it's really only the mature bone, the lamellar bone, when it becomes really self-sustaining. So you're losing that when you're completely demineralizing your dentin graft. Now, what we have done about 2 years ago, we have introduced another protocol, a second protocol. So our standard protocol is still mineralized dentin graft. So you're getting the scaffold, the slow resorption, everything we just talked about. Great, okay? Very predictable. But in some cases, you do want to, what we call, accelerate your new bone regeneration, especially for patients that we know are going to be slow healers, such as your smokers, your diabetics, your medicated, patients just went through cancer treatments or just old. These patients are going to heal slow. So for that, we have developed a new protocol, again, not so new, about 2 years ago. We call it partial demineralized dentin. And what we do, we introduce another step, which is based on EDTA. It adds 2 minutes to the protocol, and that will really give you partial demineralized, about 20% demineralized, 80% mineralized graft. So you're getting the best of both worlds. You're getting the early exposure of collagen, but you're also getting your scaffold. Okay?
Well, personally, I remember talking to you 2 years ago, and you told me about this, and yeah, I'll send you this. And, with the patients that I'm expecting slower healing, I just wait a little bit longer. I just had a couple of months. I never had a patient that told me, I have to have this restored within 3 months, not 4. never happened thus far. Usually these patients that heal from a clinical point of view, that heal slower, that we're expecting them to heal slower, they're more understanding of the situation. You explain to them the medical issues, and they're less keen of doing everything now fast, and so on and so on. So it would be great maybe to try it out, maybe to do some research about it. And yeah, well, why not? But this protocol with fully mineralized just works.
Okay. Dr. Kuperschlag, there's a question here for you from Dr. Manish. Could you please go over your technique to make the custom healing abutments using flowable composite?
You know what? I actually even have a video of this, just not on this computer. Basically, what you do, and it's a little bit hard to describe with words. It's better to see it, but pretty much what you do is that you screw in a temporary abutment, and you just make a flow outline with it. You fill it up, and then you polish it up. Just write it down in YouTube, and you should find some videos about it, because explaining it in words doesn't give it justice.
Okay, good. Let me quickly see. I think we covered most of the questions that were asked. Where do I get the Dentin cleanser? Okay, you get the Dentin cleanser from Cometa Bio or any Cometa Bio dealer worldwide. We have dealers around the world, and if you go to the website www.cometabio.com, you will see a list of dealers, or you can contact me and I'll help you. And also, since I mentioned the website, there's a lot of educational pieces on the website, articles, research papers, videos. You can also go to YouTube/CometaBio, where you can see a lot of techniques and procedures and surgeries. And there's a few more questions coming in. We'll take a couple more. And I know it's getting late, Dr. Kuperschlag, for you, but
it's almost midnight, but the energies are always high when talking about oral surgery. If people would like, we can do a follow-up webinar. There's plenty of topics to discuss.
Yeah. Okay. Okay. Great. So there's a question here. Yeah. So Dr. Fadul, I hope I'm pronouncing the name right. Are there any instances where we cannot use this technique, if there is any? So here is something I know that Dr. Kuperschlag and myself are a little bit different on. And I'll give some background. Up until recently, we have contraindicated endo-treated teeth. We did that because we didn't have enough experience with endo-treated teeth. Also, to clean up the gutta percha and the sealers is a little bit more difficult. And a lot of doctors just don't want to spend the time to do that. Recently, after, again, a lot of experience, we've been experimenting with this now for over 7 years. We have found that as long as you as a doctor, as long as you know the history of the tooth, you know the type of materials that were used for the endo treatment, and you're feeling comfortable with it, then you can vertically section the tooth, and you can use a drill to clean up all the gutta percha as much as the sealers, and then use it. We haven't had a single adverse reaction from all the cases we've seen with endo treated. I wouldn't start with it. Definitely not. Start with the non-endo, and when you get enough experience and you know the history of the tooth, you know what's been done to it, then you can do it. But I can tell you it's going to take you a little bit more time than the 7 minutes end-to-end or 8 minutes end-to-end that the typical standard protocol will take.
I think that what you're saying makes a lot of sense. However, I think that the next step will be finding a very clear protocol on how to do it. Because I know that in my hands, personally, it won't work. The last time I held a file for endo was 8 years ago, maybe. I know for a fact that in my hands it won't work. But and it's actually interesting. We can maybe try to figure out, or you guys can try to figure out a very exact protocol. And yeah, and if you're able to solve this problem, then you will make a dent in a lot of biomaterial companies' pockets because most of the teeth will be able to utilize. But it needs, in my opinion, it needs a very clear cut protocol.
Another interesting question here. I'm not sure I can give the full answer on this one, but let me read this out because I think it's relevant. Any thoughts on patients taking biphosphonates, PPIs, SSRIs, any difference in autograft versus allograft? I get asked this question, and I don't have all the research here, but I'll let Dr. Kuperschlag maybe comment as well. But as a general comment, anything autologous, okay, anything autologous that was already in existence in the patient's body, and you use it back you bring it back in. Remember, we're not manipulating it. The only thing we do is we clean it up, we cleanse it, and we particulate it, but that's it. And that's why we're getting extremely low inflammatory reaction, if any. And typically we believe the inflammatory reaction you are getting, the little bit you're getting, is due to the surgery, is due to the surgical procedure, not the graft. So in my opinion, that should explain or should answer this question. But again, we need to look into this furthermore. What do you think?
So first of all, I completely agree. Before addressing this question, we have to understand that patients with bisphosphonates are contraindicated for oral surgery, period. Unless they go through the cycle, the protocol, wait X time, and then you're clear to go. Now, having stated that, I completely agree that we would like to use autogenous. However, we have to make sure, let's say, put two emphases. Number one is that we don't have a secondary surgical site, meaning I will not extract a wisdom tooth to fill in a socket for a defect and so on and so on. I do not want to have a secondary surgical site. So I might use it in an immediate implant where I'm able to extract and reuse it. The second, and this I learned from Professor Binderman, always 100% of the patients that are taking bisphosphonates for osteoporosis, for cancer, and so on, I always 100% of the time, whenever I'm performing whatever oral surgery, whether it's a simple extraction, whether it's something more serious, I always use L-PRF. Because this combination of green dentistry of Dentin and L-PRF is amazing, because L-PRF, the cytokines in there, allow the differentiation of monocytes, okay, that comes derived from leukocytes, and a lot of people don't think about it. We have monocytes type 1 that are differentiated in M2 into monocytes type 2, and if they don't, this is what the bisphosphonates are causing, this lack of differentiation, and we're dealing with chronic type of inflammation, inflammatory stage. So whatever you do, if your patient is in the risk group for medical induced osteonecrosis of the jaw, use L-PRF always. And with the Dentin, I would always want to have something autogenous, however, never a secondary surgical site.
Great. Thank you very much. Last question, actually one next to last that came in. Any indications where this should not be used? No.
I'll be honest. I'll be honest with you. If I have a case that I know that I will need grafting, and I have the opportunity to choose. The situation allows me to choose whether to use Dentin or a different grafting material. 100% of the time, I will choose Dentin. It's very easy to answer.
Okay. Another question I got through text is, can you say something more about the device and where we can get it? The device is called the Smart Dentin Grinder by Cometa Bio. You can find out more about the device and the disposable kits on cometabio.com. Again, there's a list of dealers, or you can text us to info@cometabio.com. Overall, depends of course on the dealer and the region, but it's under $2,000. You're getting the device and you're getting 6 disposable kits, and you're all set up for your first 6 cases using it. And I think with that, pretty much we summed it up. Again, if any additional questions beyond it, you can feel free to write to either avi.coop@gmail.com. It's on the screen, or you can also direct those questions to info@cometabio.com, and we'll make sure you get the response. The recording, people are asking me about, will the recording be available? I believe so. We'll just monitor, make sure we have recorded the whole thing. I believe we did. And we will post it either to YouTube, or we'll send you a link so you can download or view the recording again, or share it with anybody that you want. Okay? So with that, Dr. Kuperschlag, thank you very much.
Thank you very much. It's been a pleasure. And
hopefully we'll do this again. Much health to everyone. Keep safe and healthy, and we'll see you soon. Bye.
Stay home. Bye-bye.